Hello, everyone. I think we'll get started in just a few seconds. So I think we'll get going. I want to thank you for attending today's webinar, Reopening K-12 Schools Safely, Real-World Examples of Effective COVID-19 Testing Programs, hosted by DNA Genotek and Quadrant Biosciences. I'm Jeff Graham, Senior Product Manager at DNA Genotek, and I'm delighted to be your session moderator. Our panelists today are Mara Aspinall, Managing Director of both Health Catalyst Group and Bluestone Venture Partners. She is also co-author on the Rockefeller Foundation's National Reports on COVID Testing, Education, and Policy Recommendations. Dr. Frank Middleton, Associate Professor in the Departments of Neuroscience and Physiology, Psychiatry and Behavioral Sciences, and Biochemistry and Molecular Biology at SUNY Upstate Medical University. He is also the founder and director of the SUNY Molecular Analysis Core Facility, where his team developed a COVID-19 saliva PCR test that has been used by over 2 million people. And Camilla Caracoli is the deputy to the president at SUNY Oswego, where she managed the comprehensive rollout of COVID-19 testing across school campuses. Our agenda today will include presentations by our 3 speakers, followed by a Q&A session. Mara Aspinall will introduce COVID-19 K-12 testing, highlight resources available to schools, and provide some examples of effective testing programs. Dr. Middleton will describe how his team was able to develop and scale saliva PCR testing for COVID-19 across New York State. And Pamela Caracoli will provide lessons learned from her experience rolling out COVID-19 testing to students at the SUNY Oswego College. Before we begin, I wanted to highlight a few tools on the webinar dashboard. At the bottom of the screen, there are multiple application engagement tools, which you can resize, move, or close. You can expand your slide area to maximize it to full screen by clicking on the arrows in the top right corner. You can submit any questions during the webcast using the Q&A engagement on the many of your questions as we can during the Q&A session, and we'll certainly follow up with others. Any additional content to supplement the session is available in the additional resources box marked with the paperclip in blue. And finally, on-demand version will be available approximately 1 day after the session. I think before we start, we had 3 poll questions for the audience to understand how each of you may be involved in K-12 testing and what stage of preparation your school may be in for COVID-19 testing for this coming fall. So our first question, what is your role in school COVID-19 testing? And I'll give everyone about 20 seconds to reply. Our next question, what stage of program preparation is your school in for COVID testing? I'll give the audience another 15, 20 seconds to reply. And finally, is your school financially prepared to launch school testing this fall? I'll give everyone another 20 seconds. And with that, I'm going to pass the session on to Mara Aspinall, our first speaker.
Thank you. Can you all hear me? Just give me a thumbs up. Sounds good? Great, perfect. So what I'm going to talk about is going back to school K through 12, and I'm going to organize it in 4 sections. What I call the good, bad, and the ugly, essentially our executive summary. Where did we end the spring, and where do we go forward from the fall? And you saw with the last question, we're going to talk about funding, but the good news is, I think for virtually everybody, there should be funding available. So I'm going to go forward from there to talk about the good, bad, and the ugly. What's good? Clearly, cases are down from a year ago. I wrote this slide 3 days ago, and cases were way down. I have to say now, you may have seen yesterday, 108,000 cases, 63%, through 63,000 is a 7-day summary. So we're not down as much. And many, many states, particularly in the South, and those who are going through surges, are between 50 and 100% of their hospitalization that they were 8 months ago. Good news, 50% of US adults are vaccinated, 80% for teachers, a third of teenagers, and vaccinations are highly effective, 50 to 90% depending on the variant. The bad, only 50% of adults are vaccinated, and net about 15% of kids, including those under 12. But few mitigation measures remain in place. Maybe that will change now, but in general, most kids are not vaccinated, either because they're not eligible or otherwise. But what about the ugly? When you talk about the ugly, these are 2 things that are not specific to the US, not specific to the situation. They really are about the virus itself. And one is that all viruses mutate. That's how they stay alive and they get stronger. And I'll talk about that. And secondly, and this is unique to COVID-19, the very high number of people that are asymptomatic. So let's look at the first piece of this, which is all about the variant. You're probably familiar with it. So you know if a random mutation occurs, it doesn't matter. More mutations occur where you see the blanks there. It's a big deal. So what the WHO came up with are 3 options. A variant of note, called it green because it's not a big deal. A variant of interest, something to watch in orange. But if it gets to red, it's a variant of concern. And that's where we are with Delta. There have only been 4 variants of concern, now called alpha, beta, gamma, and Delta. I'm going to predict here the next one that's a concern is Lambda. So what's the so what here? What do you need to think about as working with K through 12 schools? 5 questions, I believe. Are the test sites accurate? The answer is just a few. Most importantly, the antigen tests are not affected at all. All of the variants have been on the spike protein, and the antigen tests focus on the nucleocapsid, the N protein. Virtually all the PCR tests are fine as well. But does it increase cases and deaths? The answer is it does. And you can see that now. Are treatments less effective? Yes, there are some, particularly plasma transplants from a responded person. Don't work if it's a different variant. Vaccine effectiveness, we know that. And most importantly, does it raise the hurdle for herd immunity? It does, hence why we need to get everybody vaccinated. So let me start with the second piece of the ugly, which are asymptomatic cases. And this is somewhat unusual. There are a lot of studies here. I'm not going to go through all of this, but the study that saw the fewest asymptomatic is 19% in Korea to 60% at the USS Roosevelt. You can see the Diamond Princess, 46%. Very high numbers of asymptomatic people. And my 90-year-old mother was one of them, literally 0 symptoms, not a headache, not a cold, not fatigue, nothing. But she clearly passed it on to a lot of people. Next, what about, those were adults, what about kids? Well, various studies here. In Seattle, they saw kids as much as 38% asymptomatic. In Korea, 22%. But important to recognize, and maybe in Seattle, some of that 38 were people who were pre-symptomatic and then just took a longer time to show any symptoms. So in the midst of this, where were we in the spring and how relevant is that to go forward? So just very briefly, if we look at the spring, what a difference than it was from a year ago. We ended the year at only 2% of schools being all virtual and 70% of schools being traditional, meaning 5 days a week. This is tremendous, and we need to keep this going. And the Biden administration, and maybe one thing that all governors agree on, is kids getting back to school. So if you think about that, does it differ by state? I'm going to do this really quickly to say it kind of sort of does, but really only California is the only state below 40% of an in-person index. The only difference that you'd see is some urban schools have a slightly less, about 5% fewer that are open. But when we were looking in June, essentially everybody had the vast majority open. So how do we keep that open? And I'm going to go through this quickly because we've got a lot of great information to go through. But the fundamental things here are threefold: vaccination, mitigation, confirmation. And confirmation is only available through testing. So first, we'll talk about vaccination. You're probably familiar with all of this, when people are eligible and what the vaccination rates. Kids hovering about 33%, 1 and 2 doses, but clearly the fully vaccinated is increasing. And all of those numbers, after about a month lull, before Delta reared its ugly head, are increasing, but we're nowhere near what we'd love to be, is 70% plus of the population. Why is this important? Well, in Israel, which is 3, 4, 5 months ahead of us, the COVID spikes, they're not seeing a lot, but when they are seeing it, 40% are kids 10 through 19. So these are kids not at home, not vaccinated for the most part, and are interacting with the world. This is important. If you include the 0 to 9, we're talking more than 50% of cases are under 18. So how do we know that testing works, and how do you deal with the fact that there are a lot of these kids? So in the UK, and this was just published, today's Thursday, Tuesday, which is testing versus quarantine. There's a lot of data here, but I'll go through it, and I have an apology. There's a decimal place missing there, so I will correct it when we send out the slides. On my left, in the red is the control group, and that shouldn't be 18% of days lost. It should be 1.8% of days lost. But if you look at the intervention group, where instead of, if there was a positive case, the control group just sent everybody who had contact home for 10 days. What the intervention group did is said, no, they want to do daily antigen tests for these kids. And what they found is instead of 1.8, 1.47 days lost. Doesn't sound like a lot, but it's a big deal. And with the control group, they didn't count the days that are home because they could be online. So it's key. And in this case, with a pretty big sample, 100 high schools, to do that. In addition, what they found is 61%. So essentially, the 1.4 versus the 1.8, 40% reduction for those who were fully compliant. And for teachers, 61% difference in absence days for those who are tested regularly versus just automatically quarantining. So why is this important? You all know this, the Delta variant. But what I think is interesting here on the right is the Alpha variant became the dominant strain once it was very visible in 3 months, Delta in 1 month. And only 6 weeks, it got to 83%. So this is unlike anything we have seen before. Vaccines work. You know, at the end of March, CDC said 90+% effective. But if you look on the right and you see the various different countries, the blue line and on the right-hand side of each graph shows the reduction in efficacy for Delta. So we still want to go back to school, but we have to be more cautious because of Delta. So the other way to deal with this, if we can't get everyone vaccinated, is mitigation. It sounds good. I think that there are 6 different types of mitigation. The top 3 are mitigations that I'm going to say are relatively easy to do. Respiratory checks, hand washing, and school hygiene. And while I can't generalize, I'm going to try here. There are not a lot of protests about people saying, I don't want my kid washing their hands. But the bottom list, there is a lot of controversy. Clearly, surveillance and monitoring, what does that mean? It scares people. Physical distancing, I don't know. 6 feet is really hard. 3 feet is hard. With younger kids, with older kids, I know we've talked about it, but I'm going to say in reality, it's almost impossible to do throughout a school day continuously. And then the controversy about masking. So what we know is that 2 days ago, the CDC gave mask guidance. I don't need to read it. You know what it says. That says mask, indoor masking, teachers, staff, students, and visitors to K-12 schools, regardless of vaccination status. Some people were thrilled. A lot of people were very disappointed to do this. It does say put other measures in place. So this is a key issue. Well, sounds good, maybe, but like the split for the rest of the country, 22% of states are requiring masks in the schools, but 20% of states are saying you can't mask, you can't mandate. Now, the vast majority, the green here, you can do what you want, but it is a tough situation out there. So what I am going to say is if you look at all 6 of those mitigations, understanding the top you're going to do, I hope, and are easy to do anyway. The bottom are tough to do, and you may be restricted. It's all about testing. Granted, I'm a testing evangelist, but and I've worked with testing companies. I'm on the board of a testing company, OraSure. We have to be aware, however. So I call it confirmation. After vaccination mitigation, all about confirmation and testing. So how does this work? Well, I see it as a threefold approach. We have a national program, goals, and strategy, and that's where the money comes from. Coordinated regionally and implemented locally. The requirements I won't go through. You could see them in the slides when we send them out, but making it easy for all of you, effective, accessible, and clearly affordable. So if you start testing, you can continue. There are a lot of steps to going through this process. What I would emphasize to you, we started with 2 steps, asymptomatic testing, and then if you use pooled PCR, follow up with either individual PCR or antigen tests. But what we found is it's highly, highly desired to do initiation testing. And with that initiation testing, either doing small pooled PCR, individual PCR, or giving everybody a test to do at home themselves. So this is key when you start your semester, so you don't start the school year with lots of positives in your classrooms. You probably know how rapid antigen works, so I'm not going to go through these, but it could be used as initial testing or for pool deconvolution after using PCR, and you'll hear more about that. We've got a program throughout the country on doing this, but I think the key is thinking about how to choose your options. And this maybe is a very simple graph that shows on the left, there's PCR testing and antigen, there's lab and on-site, although most of the testing is either lab-based PCR or on-site-based antigen. So the first one and the last one. They can both be equally effective. You need to think about what works for your school. Big difference in test and time to test results from 24, hopefully, hours to less than 30 minutes. But what are the considerations? Test sensitivity and specificity, frequency, time to results, logistics, and I'm going to say finally cost, because as you'll see in a minute, cost should not be an issue. But why is this important? Well, it's key to understand the life cycle of the virus. Again, you probably all know this now, but I continue to see lots of people saying, I just got off the plane, I want to see my mother, I'm going to take a test today. Unfortunately, there's no test that works 12 hours or 2 hours after you get off the plane, if that's when you think you're exposed. Typically, 3 days, 4 days, 5 days. With the Delta variant, we're finding 4 days. That's when you need to test. And what's key is having quick answers, whatever way you do the test. Because if you have to wait, like we did in the middle of the pandemic, 3 or 4 days, you're then spreading the virus, even if you are not infective. And I think the biggest change that's come with the CDC recommendations yesterday is an acknowledgement that somebody who has the vaccine, who has no symptoms, but is positive, can spread it. So what are the processes? I'm going to say there are 4 pieces. You coordinate and go through the administration. You communicate. That's the number 1 key thing you need to do. And start getting consents from your parents and adults. Then choose your testing modality, set up your facility. It doesn't need much setup for most tests, but you need at least a decision. Do you want to do it in the morning as kids walk in and before they get to their classrooms? Do you want to do it in the school bus line or in the carpool lane, depending on how you do it? Do you have a lot of people who walk to school? Then you need to discover how you're going to do results reporting. What are you going to do for your school community? And then what are you going to do for your local, state, or federal requirements for your testing? Does testing work? Yes, 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 and yes. In this modeling by Mathematica and Rockefeller, we found that schools that started testing had a 50% reduction in viral cases if they did regular screening. But what else does it do? I'm going to skip the left-hand side, the small private school. But if you look at the right-hand side, when we asked teachers, are you confident about going back to work? It was like 12%, not much. After testing, 80%. We asked parents, were they confident? 28%. After testing, 84%. It makes a big difference. But is the risk so big? You probably know this from your community, but we looked at rural and suburban and urban. New York City, positive rate in the schools, 0.5, positive rate in the community, 5+. Colorado, positive rate amongst teachers, 0.5, usually students are lower. Positive rate across the state, 4. Same, we looked at El Paso, Texas, 10% community rate, 1% in the schools. So schools are generally safe, but let's make them even safer. Not going to go through these, but you could see Massachusetts, Baltimore, Delaware, California, Ohio, all have successful programs, and you can read the slides. So I'm going to end here because you've got other teachers. I'm just going to go through other teachers, well, we can call ourselves teachers today, but other presenters to say there are real options for testing. There are 4 options. I won't go through this one, which was the original funding to schools. Most of that has been spent. There are 3 options. ICAT, which is $250 million, but it's ending in September, so not really relevant. They're not taking any more schools. The 2 key programs are the coordination hubs, Operation ET, $650 million. It was originally K through 8, now it's K through 12. It was originally just public, now it's public, private, and charter. But this is coordinated through 3 major hubs, and they've already picked their technology. So if you're part of that program, you don't have a choice on technology. The biggest program, which is the one that I've been working on, is the National Testing Action Program, ELC, through the ELC, and that's $10 billion. And it goes not till, the ELC program goes to November 21. This goes to July 22. So throughout the entire next school year, and you can choose in most states what you want to do. So how much money do you have? You do not need to apply to the federal government to get this. You need to work with your state, and most states don't have an application process either. Again, you'll get these in writing, but you could see that this is the states, and you could see even small states are getting tens of millions of dollars. My state of Arizona, $220 million. These are very large numbers. How can you use these dollars? Well, this is the same data, but just in a map. 85% need to go to the test, the PPE, or direct staffing. 15%, and this is really important, can go to the coordination or the management. So if you need somebody in your school who's not testing, but working to get consents, working to coordinate between the classrooms, anybody who's doing that, who needs a data collector's report, you can get that paid for through this federal monies. Now, some states have put restrictions, but most of the time not. Most of the time, it's all about the idea of making this easy, and no school should say they can't test because they don't have the money. So with that, in summary, vaccines are great, best vaccines we've ever had, but they're not 100% effective. Duration, we don't know. Lots of articles this week on this, and that it maybe lasts 6-7 months. Not everyone's going to be vaccinated, and we know so well about mutations. So it's all about surveillance, and testing is essential to avoiding recurrence and surge. So with that, I know we'll have time at the end for questions. I will conclude and hand it over, I think, to Frank for the next talk.
So that was an outstanding lead-in. Thank you very much. And what I'll focus on more will be the development and deployment of one particular type of testing and how well this worked across New York State. And none of us will forget what we were doing a year ago and the time we spent from March 2020 until now. It has changed the world. At the beginning of the pandemic crisis in the United States, you may also recall some of the major challenges we faced as a society with no immune protection, learning how to cope with tracking and defending against a virus that we could barely detect. And so there were several things that we needed a year and a half ago because there were too few approved PCR tests available for mass screening. and there were flaws in the design of the test that had been developed by the CDC. That test and others that quickly followed it used excessive amounts of reagents. They took too long to generate results from a lack of consideration of the best design possible. There were also too many tests that produced false negatives and false positives because of a lack of consideration of many of the aspects that go into optimizing the test. For example, there was no control over RNA degradation, and RNA is what the virus is made of. There are biofluids throughout the exterior surface of the body. You'll find those in the nasal passages. You'll find those, certainly saliva represents one of those. And these are rich in enzymes that degrade RNA. If you don't control those enzymes, you will suffer a loss of sensitivity and you won't be able to detect the virus. There was also no control for DNA contamination with the tests developed by the CDC as well as those in New York State and others. There was too much of a reliance on the nasopharyngeal swab, that deep nasal swab, for population and patient screening. And the issue with that was the requirement of a healthcare provider to actually perform the test. What we realized in February and March of 2020 is that we really had 7 things that we felt we could add that would be useful for New York State. And we wanted to be able to use higher throughput methods with less reagents. We wanted to be able to control the factors that led to high false positive and false negative rates. We wanted to be able to develop a test that people could perform in their homes, not simply tests that were approved for use in a hospital setting. We wanted to be able to reliably sample other sources than just those deep nasal swab sources. We also wanted to have complete confidence in the safety and stability of the sample that we had collected. We wanted to create an assay that was highly resistant to viral mutations. And we wanted to be able to preserve the viral RNA for tracking mutations themselves. So we developed a plan based around these goals. And the journey we took is essentially summarized here. What you're looking at in the upper right of the slide is a schematic of some of the major genes in the virus genome in those blue bars. And several of the tests that have been developed targeted different regions of the virus genome. You can see the CDC test targeted a region designated N1, N3, and N2, and that means it was focused on the nucleocapsid gene of the virus genome. The Pasteur Institute targeted another region with those 2 circles in blue underneath the ORF1b. There were other regions targeted by the Charité assay and Thermo Fisher, and those are indicated below. What we decided to do was, rather than use the CDC test, we wanted to actually compare and contrast all available validated tests, see which ones were the most sensitive, and then see if we could make it work even better than originally developed on saliva, which had not been suggested for use, and make sure that the assay would be resistant to mutations. So our experiment, if you will, the solution that's listed here, was to combine 2 CDC primer probe sets in one of the fluorescent channels that we could use. That's called the FAM channel. 2 of the Pasteur Institute primer probe sets in another channel, the HEX channel, and optimized human gene in a 3rd channel, that's the Cy5 channel. And we would put this potentially useful assay really to rigorous testing, determine the limit of detection, determine the clinical utility, demonstrate the stability of the RNA, and jump through many, many other anticipated hoops. what we found was that the CDC contribution to the test, if anything, was increasing the false positive. So we actually dropped that initial part of the assay that we had developed, and we went from one that included the CDC primer probe sets to one that did not, and it actually helped the specificity of our test. Our test relies on the use of a stabilizer for the RNA that is collected, and you can see here in the upper right of this slide the collection device that we used. And this was something that was developed actually by DNA Genetech, and there's the swab sticking up out of it. And this swab and the solution that it's placed in after collecting saliva for about 10 seconds is unique because it stabilizes the saliva and includes an enzyme that will help degrade not only viruses and bacteria and other contaminants, but also the enzymes that can so powerfully eliminate all the RNA that's there. Those are those ribonucleases that you're seeing an old article more than 50 years ago in the lower right corner. This was a device that we had actually used for the past decade extensively in studies of children with autism and studies of adults with concussion and studies of Parkinson's disease subjects. We were very comfortable with using this and studying the RNA that we could preserve from it. This also represented a novel reagent supply chain because nobody in the United States or other countries was using this device. We developed the test, we had validated it, we received New York State Department of Health authorization to begin statewide surveillance with the test in late July. We then received official approval from the Department of Health in New York for individual testing in late August, FDA, EUA authorization in mid-September, and then after authorization, we went through a blinded analysis, and our test was determined to be the best in class, the most sensitive and specific saliva test. It's also resistant to the mutations, unlike many other tests. But one of the key components, right from the beginning that we focused on, was also how to use this test, this particular swab, in a pooled testing methodology. And that was achieved and did receive EUA approval earlier in 2021. It also represents the best in class for pooling sensitivity. So I want to take you through just a few arguments in favor of choosing a highly sensitive test. The CDC test or the Yale saliva test have a sensitivity that's actually displayed on this slide of 18,000 copies of the virus per milliliter of biofluid equivalent. In the case of the CDC test, that would be nasopharyngeal swab fluid in the collection swab device. In the case of the Yale test, that would be in saliva itself. 18,000 is much higher copy number than you need to detect it with our test. So our test, we can detect as little as 600 copies of the virus. If you look at the rapid antigen test, you need 150,000 to 300,000 copies of the virus to be present in order to detect it. So there are orders of magnitude more sensitivity associated with this nucleic acid PCR-based test that we had developed, and it is the most sensitive saliva test. The only test shown here indicates greater sensitivity is one that was developed using the deep nasopharyngeal swab by PerkinElmer. The sad part is that the CDC test and the tests used by LabCorp and many, many others lack the sensitivity to the extent that they will miss more than half of all of the cases. And this allows for exponential increases in positivity rates. And we've seen that happen. Too many times, nursing homes and sometimes schools relied on deploying tests that simply lack the ability to detect persons who may have been pre-symptomatic or asymptomatic throughout the whole course of the illness and spreading occurred. Pool testing was something I mentioned before. There are a lot of potential advantages of pool testing. You heard their prior speaker mention some of these. Can certainly reduce the drain on reagents and supplies. There's some considerations about potential disadvantages, and we wanted to address those. So what did we come up with? We came up with a process that is basically summarized in this slide, where individuals would swab with those DNA Genetec devices. These, perhaps as illustrated here, might contain one positive sample in a mix of 12. We collect the fluid from these individual collection devices into a pool tube, but we preserve the individual swabs. And that means that the swab that was inside the mouth containing the virus, if any, is still available for reflex testing without collecting a new swab. We test the pool swab, we generate results within a day, and we can clear whole groups of students or faculty as presumed negative. And when we have a positive pool, we can do immediate reflex testing by breaking out or deconvoluting these individual swabs that are in the pools. We also developed a reporting mechanism around this for individuals to receive the results as quickly as possible. The choice of the pool size matters a great deal. You'll hear a lot about pooling, but we actually have the highest pool size number authorized by the FDA for pool testing, and that's 12. We've shown that our test can go much higher than that, can go up to 25 without necessarily losing sensitivity. But when you hit that high of a pool size and the pool is positive, there's a much greater burden in terms of the number of tests you have to perform as a follow-up. So based on a lot of modeling, we actually chose an optimal pool size of right around 12 to deploy across the New York State schools, although there was flexibility in this. When rates creeped up, we would commonly advise schools to reduce their pool size down to 10 or 8. We saw no loss in sensitivity compared to individual testing. What you're looking at is the cycle to threshold value and the PCR test plotted against for the pool, plotted against that for the individual on a reflex testing. And even though it took 1 to 2 more PCR cycles to show up in the pool, it always showed up. The frequency and timing of testing and the results turnaround matter. Our previous speaker mentioned that as well. The gold standard would be you test daily and you get the same day results. If you can do that and you have a test as sensitive as ours, you would remove more than 96% of the infections. Compare that with testing weekly and taking 7 days to get the results, which was a reality a year ago in many locations in this country. And you can see there's very little gain from the testing program. What we were able to achieve was testing weekly with 1 or 0 same day or 1 day delayed individual reflex testing results. And this removes 60 to 70% of the infections by our estimation. As a campus or as a university system, the State University of New York achieved even better than this, however, because they didn't rely exclusively on testing. There were other measures in place, and you heard some of those mentioned. With our pooled sensitivity, we were able to scale up, and our one lab in Syracuse, New York, could process 30,000 samples a day and thereby test the entire on-campus SUNY population every week in a single laboratory. Across the fall and spring semesters, we tested just under 2 million samples from over 80 colleges and universities, state agencies, and schools as well in New York State. Because we preserved the RNA, we were also able to complete full virus genome sequencing of more than 2,000 positive samples from New York and look at the vaccine efficacy in our state population that we were testing, and also look at saliva antibody tests. This is a quick snapshot of the genome diversity that we detected in more than 2,000 positive samples. And you can see that most of the mutations are showing up in the spike protein in the nucleocapsid region of that virus genome. And these are particularly troublesome regions because they can make the virus more resistant to vaccines, can cause other diagnostic PCR tests to fail. Ours is not based in looking at these regions. Ours is based in this much more stable region of the genome. And more importantly, mutations here can result in more rapid disease spread. This is a map of the 6 variants of concern or variants of interest that we identified in our testing populations. The size of the Venn diagram is reflective of the number of positive cases sequenced on these campuses and schools. And most of what we saw through the spring was the Alpha or UK variant, but we also had some campuses that were dealing largely with the New York variant. We did detect, as shown here, one of the very first Delta cases in April in New York State. This is a brief snapshot of the most recent 500,000 tests that we actually performed here. And you can see we're comparing the outcomes for people who were vaccinated versus those who were not vaccinated. And definitely, we saw a reduction in the positivity rate in people who were vaccinated, but it wasn't perfect. So the breakthrough rate in anyone who's vaccinated was approximately 7% in this campus population, but it was definitely not equivalent across the vaccine types. And the best way to interpret it is just to look at the efficacy, which is the inverse of the relative risk. So people with Johnson & Johnson vaccines or one shot of the Pfizer or Moderna had about a 2-fold reduction in their risk of the virus, of testing positive. But those who received 2 vaccines of any of the RNA viruses were much better protected, so 90% or 95%. And again, this is on a backdrop of individuals across the New York State that were heavily representative of Alpha variants. Overall, we did see a 10-fold reduction in positivity rates in our campus populations compared to the surrounding communities, 0.24% versus 2.5%. You saw that Alpha and Delta variants are not equal. There is a great deal of concern about reduced efficacy of protection and vaccination in the face of the Delta variant, and we've certainly seen that. We've also been able, through saliva collections, to actually look at antibody levels, and we've been doing this since the very end of December in collaboration with OraSure. And this is an example of the confidence intervals, the 95% confidence intervals of antibodies in individuals who had a Pfizer vaccine. And I'm showing you the results for one person who received their vaccine shot approximately 130 days previous. And so you can tell that there is a continual reduction in the amount of antibodies that are present across time. These curves look different for the Moderna vaccine. They look very different for the Johnson & Johnson, and they look different for persons who just had a natural infection. But we think measuring saliva antibodies can also help guide the call for booster vaccines in individuals who would benefit from it. And ripped from today's headline is something I put on the right side of this slide, where Pfizer announced, indeed, that a 3rd dose of their RNA vaccine can truly boost the protection much, much greater. So there is a prediction here that we can make that we will all have a reduction in the strength of resistance against variants, the ones we face now and future ones, but will all benefit from boosters that are being developed. So the lessons that we've learned, it's possible to have a strong impact, and saliva holds one potential means of reducing the influence of this virus in our vulnerable populations in our campuses and schools. With that, I will turn it over to Pamela.
Thank you, Frank. And I have to say, I made a number of notes through both of those presentations. I'm heading into a 3 o'clock campus leadership meeting here, and I do think that this updated information is really helpful and will help us make some decisions as we're writing our guidelines for the fall, like a lot of the schools that are on the call today. So my role here on campus, I don't have a medical background, so the information that I'm presenting is really, this is the stuff that I'm going to be talking about. I'm going to tell you about how many students we tested, how many employees we tested. I'm going to talk about the testing facilities that we created to conduct the tests that Upstate and Quadrant have developed. And I'm going to talk about the testing data and the compliance measures that we used on our campus over the last 15 months. And then overall, what we know our students and our employees have experienced and some of the feedback that we've gotten from this experience. This is probably the two numbers that I would point out here are really the fall and the spring. You can see we did more than 3 times the amount of testing in the spring compared to the fall. We were one of the first campuses to conduct these tests. We did a baseline test. We were one of the first SUNY campuses to do baseline testing, which means that we tested everybody as they came to campus, every single student and every single employee as they came to campus in the fall of 2020. And then, winter and summer, those are just smaller populations anyway. But we really ramped up in the spring of 2021 because we were still coming off from a pretty rough winter, as everybody remembers. And our average there was 3,600 tests per week, and we were only testing 5 days a week. So we were well over, 700 tests per day. That I did make a note that our largest test day, we did 1,487 tests on one day. And that was probably, Frank, when we had, a spike on our campus, and we were really, pulling as many students into the testing center as possible. Focusing on those two areas, the fall of 2020, out of 22,000 tests, we did have 399 positives. That's an incredible number, and meaning it's significantly small. And in the spring, for 57,000 tests, we had 575 positives. And what's important to note is what the other presenters were saying. There's no question in my mind, not having this capability to identify and isolate immediately would have rendered a very, very different semester for our students. So we were able to continue with their educational programs, and we didn't skip a beat. So but our grand total of testing over that entire academic year was 83,160 tests, and that actually goes right into the summer as well. We have summer sessions occurring as we speak. So here are our testing facilities, and I like these photos because they really do underscore some of the transformation that we've had in testing on our campus. We started off in a very large gym. We had 12 stations. We used outside contract nurses to do the actual testing. And we were, back in those days, we were also doing the pooling. And so we didn't have staff that could do that on our campus. So that was all external hires that we used to run our testing center. But the photo on the right shows 3 desks. This is what we currently have set up. It's really, it's more than anything, it's digitally driven now. It's a lot less physical. It's a lot safer. It's a smaller operation. For the fall, we're only going to add 2 more stations, and we anticipate testing somewhere between 2,000 and 3,000 students per week. Again, focusing on the unvaccinated students at this point. And then here is so we do use our box office. We didn't have a lot of events occurring last year, as like a lot of campuses. So our box office is still actually being used for all testing reservations. Back then, we did faculty and staff separately. Now everybody is testing together. And we do have our own campus check-in. So we connect a campus ID with a test kit barcode. And so we are able to manage our own data as well as match it to what we get from upstate at the end of each day. And then the campus database is really, it's governed by two offices. Health Services is a team of nurses that oversee the student database, and our HR office oversees the employee database. And then this is my last slide, and this just gives you a snapshot. So we have 7,400 students, 1,700 employees, and so we did 83,000 tests, as I indicated, since August 12th of 2020. I would tell you that anyone that participated in testing would say that it's incredibly fast. We've got it down to less than a minute per test, and because we can do it across a number of testing stations, it's obviously more than that. It is very easy to manage. It's very safe. And it is non-invasive. I can't tell you the relief that I see. I just had a whole group of students come through as part of an orientation program for our campus. We had 97 students come to campus. They thought they were getting the deep nasal test. They were thrilled to get a saliva swab in their mouth instead. And the only feedback I would say is if we can make them flavored, that would be fantastic. And then, of course, certainly, but and this may not pertain to all the other schools, but it certainly pertains to us. The cost is significantly less than a lot of the other options, but we're getting the sensitivity we need to make decisions pretty quickly on our campus. So that's all I have from SUNY Oswego. Thank you.
Thank you so much, Pamela, and actually to all three of our speakers for three fantastic presentations. And there was a lot of information there, and so we went a little bit long on the presentations, which is absolutely okay. We probably only have time for one question, and one of our participants has asked a question about PCR versus antigen, and his concern was that he tested positive on a PCR test, but negative on an antigen test. And I think this speaks to, I guess, just all the options that are out there for schools, antigen versus PCR, pooled versus not, and different sample types. And I just wanted to put it to the panelists, any advice there, and maybe you could respond directly, probably Dr. Middleton and Mara, on the concern around antigen versus PCR.
I'll absolutely respond if I can. So the typical
you go first.
50% positive rate on rapid antigen tests is the equivalent sensitivity of approximately 31 to 32 cycles of PCR. So that represents about half of all of the tests that we identify as positive. So we know from practical experience that the best rapid antigen tests available, the most sensitive ones, still miss at least half if the testing is only done a single time. Rapid antigen tests, if they're used daily in persons at high risk, can catch a person when they have a higher viral load. But if it's just used once, the hit rate is about 50%. So people should not be surprised by this. We also see the individuals who are vaccinated tend to carry a somewhat lower viral burden that we've been able to detect. And this will push their positive levels of virus into the region that's more likely than not going to result in a negative rapid antigen test.
And I'll add to Frank's piece, but I'm probably more positive on rapid antigen. But I think the key that the FDA has now talked about is serial screening. Antigen tests are less sensitive. They will miss, if you think about the virus, I had this on one of the slides, it goes up very quickly at the beginning of an infection. And with that time, antigens might miss a emerging infection for about 14 hours. But certainly if it's a very low viral load. If you do it twice and you're on your way up, you are more likely to catch that. However, if it's at the end of infection and you're using it to test out, then you could use an antigen test as essentially the infectiousness test as opposed to the infected, because PCR, as in my family, most common, PCR test tested positive for my family members 40, 45, 50 days after they were post-symptoms. So they were probably not shedding enough, but a sensitive antigen test was capturing them. So on the way up, you want to be cautious and probably do 2 antigen tests if you have that sort of a challenge and you want to be much more sure.
Great, thanks so much. We are out of time. I think we could probably have a long discussion with this panel, but I will close it there. I've got some contact details showing on the screen for DNA Genotech, and we actually provide the sample collection device, the swab device, and Quadrant Biosciences, who actually they provide a saliva-based PCR test. And with that, I'll close the session. I'll thank the presenters again very much for participating, and thanks so much.
Thank you.
Thank you.